Friends, let's see endometrial cancer. This is again an important cancer from clinical as well as MCQ point of view. See endometrium, it's found more in developed countries than in developing. We are still struggling with CA cervix, CA ovary, CA breast naturally. But developed countries, the percentage is almost 20 to 25% of all genital carcinomas. In India, CA cervix still predominates. So only 5 to 7% of genital cancer contributes to CA endometrium. This is a cancer of old age. Remember this sentence. This is a cancer of old age. Peak incidence is around 55 to 70 years. Means even after menopause, this cancer can be there. 20 to 25% seen in perimenopausal age group, and only 5% of cancer endometrium is seen in young women. That means women less than 45 years. The incidence is found very high in high socioeconomic status. Age around 55 to 65 years. Family inheritance is very important. Lynch 2 syndrome, MCQ. There is HNPCC association. This cancer can be found in association with colorectal carcinomas, gastric cancers, small intestine cancers, as well as ovarian cancer. Race is most common in Jews. What is the etiology? Whenever there is exposure of the uterine endometrium to unopposed estrogen, that will lead to growth of the endometrium. Estrogen acts on the endometrium, proliferation. Proliferation leads to hyperplasia and then to cancer endometrium. So the way in CA cervix we have CIN, that is cervical intraepithelial neoplasia, as a pre-malignant condition. Fortunately, in this carcinoma also we have a pre-malignant condition called as endometrial hyperplasia. So if we can detect the patient in this phase, we can avoid further consequences. So when you remember the etiology of CA endometrium, instead of going for any mnemonic, I would suggest you to remember this cause, that any condition you know where there is unopposed estrogen activity, or if there is excessive and high level estrogen available, all those causes just blindly tell them as causes of CA endometrium. So have this logic: endogenous or exogenous sources of estrogen unopposed. Unopposed, why I am saying? Because use of OC pills cannot be a risk factor. In OC pills, they are combined pills. There is estrogen and then progesterone is added to that. Progesterone always causes secretory changes and thus it causes atrophy. It doesn't lead to hyperplastic endometrium. So unopposed estrogen. Now let's see which are those. Family history, as we said, Lynch 2 is very important. Genetic, dietetic habit, familial Lynch syndrome. So this group in family history is very important. They share all these things, and thus if there is history of CA endometrium in patient's family, we should pay full attention to that history and screen her accordingly. Hypertension, obesity and diabetes. This is called as Corpus cancer syndrome. Again MCQ. CA endometrium is always associated with these three things, and if they are together, then it is called as Corpus cancer syndrome. Corpus, the uterine corpus, cancer of the corpus, and the syndrome includes hypertension, obesity and diabetes. Again, all the conditions which are related with uncontrolled estrogenic action. Hypertension, obesity, insulin resistance, androgen conversion, estrogen formation leading to hyperplasia. Diabetes, insulin resistance, again there is estrogen formation. Extragonadal sources adding to the endogenous estrogen leading to endometrial hyperplasia. Simple causes like late menopause, long time estrogen exposure, early menarche, again adding to the time of estrogen exposure. Atypical endometrial hyperplasia. As I said, that endometrial hyperplasia is a pre-malignant condition in which we have simple type and complex type, with atypia, without atypia. So if there is atypia, means the cells are showing atypical changes, mitotic activities, then those hyperplasia, they have higher risk of getting converted into CA endometrium. Unopposed estrogen and ovulation. So think of PCO, chronic anovulation, HRT if progesterone is not been added to, granulosa cell tumor of ovary. It secretes estrogen. So wherever estrogen is unopposed, it will lead to CA endometrium. PCOS, there is no ovulation, so only estrogen goes on acting, hyperplastic endometrium, leading to CA risk. Nulliparity, low parity. Again the same thing, estrogen excess. Tamoxifen for the treatment of CA breast or radiotherapy would again add to the risk of developing CA endometrium. Now let's see endometrial hyperplasia in detail because that's a pre-malignant condition. It represents the spectrum of morphological and biological alteration of endometrium ranging from an exaggerated physiological state to carcinoma in situ. Causes again continuous unopposed estrogenic action. Estrogen stimulates the estrogen stimulated endometrial carcinomas are well differentiated. But if carcinoma takes place in atrophic endometrium, that is in postmenopausal women, they are poorly differentiated. When the tumor is well differentiated, the prognosis is good. When the tumor is poorly differentiated, the grading increases histologically and prognosis is bad. Now the types of endometrial hyperplasia, simple and complex. Simple can also be called as cystic and complex as glandular. Now see the differentiation. If simple hyperplasia is with atypia, there is 8% chance that it will lead to CA endometrium. So whenever there is atypia present at the cellular level, it is more risky. And see the difference, if without atypia, then only 1% has a progression to CA endometrium. In glandular variety, in complex, if it is with atypia, it is almost around 29 to 30%. And without atypia, it's only 3%. So whenever you have atypia mentioned in the MCQ, you have to always think that there are higher chances of this hyperplastic endometrium getting converted to CA, and that's why treatment has to be more radical. Understand the point? There are more chances of this condition getting converted to carcinoma, so the treatment has to be more radical in the form of total abdominal hysterectomy along with salpingo-oophorectomy. Histologically, tumor has 5 types. The most common type is adenocarcinoma because endometrium is glandular endometrium and it has adenocarcinoma as the most common variety. Most malignant variety is clear cell carcinoma, presence of Hobnell cells. Clear cell carcinoma is the most malignant variety of CA endometrium. It is considered as very poor prognosis case. Papillary serous and clear type, they have worst prognosis, both of them. Other types are adenosquamous or squamous cell carcinoma. And histologically, this tumor is graded into 3 grades. Grade 1, where there is glandular pattern maintained but atypia present. Grade 2, some glands show papillary pattern and are solid. And grade 3, solid glands with cellular proliferation and lost glandular architecture. Higher grades have very poor prognosis, they spread faster, and most importantly, they have early lymph node involvement. This point you have to remember here, that whenever the grade is high, we have to go for lymph node sampling when we are performing the surgery, because high grade tumors have great chances of lymph node involvement. How the patient would present? What would be the clinical features? Many of the times, almost they remain asymptomatic for a while. Then as it progresses, it would start with abnormal bleeding. This bleeding can be anything. Menorrhagia, that means excessive bleeding during menses. Intermenstrual bleeding, that is irregular bleeding. Or post-menopausal bleeding. Because you know the age group, so patient may start bleeding post-menopausally. There can be watery and offensive discharge. Simpson's pain is classical of CA endometrium, MCQ. Colicky pain referred to hypogastrium or both the iliac fossa is called as Simpson's pain. It is seen in CA endometrium. By manual examination, cervix looks healthy. You can see some discharge coming out of the os. On per vaginal examination, uterus can be either normal or it can be atrophied because most of the times patients are menopausal, or it can be enlarged if it is associated with, again, hyperestrogenic conditions like fibroid. If the uterus will be enlarged, there can also be presence of pyometra because whatever secretions these cells have, if there is cervical stenosis, those secretions get trapped inside the cavity, gets infected. There can be collection of pus. Along with this uterine findings, go for the adnexal masses. There can be presence of estrogen secreting tumor, that is feminizing tumor, granulosa cell tumor. Growth protruding through os, that can also be seen. Or there can be spread of the growth to the vagina or urethra. Whenever patient presents to us with postmenopausal bleeding, we have to think of few causes to rule out other pathologies. Most common cause in postmenopausal group is endometrial atrophy. The endometrium is atrophied and that is why the bleeding is there, almost 60 to 80% of the time. Endometrial polyp in 10 to 12%, endometrial hyperplasia in 5 to 10%, endometrial carcinoma in 10%, and if the patient is on HRT, there would be history of irregular bleeding postmenopausally. So we have to think of all these causes and investigate further to conclude which cause is present in our patient. What are the investigations in CA endometrium? Simple investigation is endometrial aspiration biopsy. It's an office procedure. It should be the first step in evaluating the patient. Means, whenever there is a patient with postmenopausal bleeding, what next? Should be endometrial aspiration biopsy. Simple procedure, no anesthesia required, small plastic catheter. Patient is in OPD with you, just put that and take endometrial sample and send it for histopathological examination. Almost 90% sensitivity is there, sometimes it's up to 96%. So every patient with abnormal uterine bleeding at that age group, endometrial aspiration biopsy is must. If not, then go for DNC, that is endometrial curettage or fractional curettage or dilatation and curettage, whatever you can say. Fractional curettage gives us two samples. One is from the endometrial cavity and one can be from the endocervical cavity. So it tells us that whether the CA is from endocervical region, because both have similar kind of endothelium. So if the growth is from endocervix, we have that, which endometrial biopsy won't be able to tell us. So fractional curettage becomes investigation of choice, but the first step in evaluation is endometrial aspiration biopsy. We are covering 3 MCQs: commonest investigation, investigation of choice, and first step in evaluation. You can also take help of ultrasound. In patients who are not menopausal, if the endometrial thickness is more than 8 mm, that means 10 mm, 12, 16, 18, they are suggesting that patient has either endometrial hyperplasia or CA. If patient is menopausal, then we expect the endometrium to have atrophy and it should be less than 4 mm. If it is more than 4 mm, it's an indication to evaluate the patient. We should not let the patient go home. Immediately to take an endometrial aspiration biopsy and get the histopathological report very clear. Other investigations, hysteroscopy and biopsy, very specific. Put a hysteroscope, look at the cavity and take the biopsy if you see any lesion. So very specific investigation. Pap smear, less sensitivity. It will help us to catch because the exfoliated cells from the endometrium will be captured on pap smear, but not very sensitive, only 50% sensitivity. Doppler, it will show low resistant flow, so it will guide us. CT and MRI will also give us information about the spread, whether myometrial invasion is present, whether it is not present. CA125 again not very specific but has prognostic value. We can do chest X-ray to rule out metastasis, and PET-CT can also be helpful. Now let's see if we catch the patient in the stage of endometrial hyperplasia, what are we supposed to do? Divide our patients in two groups. If we have a patient in premenopausal group, she is menstruating, and our patient is postmenopausal. Now we all know that if the patient is young, she usually wants to conserve the uterus. If she is menopausal, there is no much point in conserving the uterus. So we can be more radical in the treatment. That's the principle. Young patient, try to conserve the uterus. Now we have to evaluate the risk. If it is simple, the risk is less. If it is complex, the risk is little more. If it is simple with atypia, the risk is more than without atypia. If it is complex with atypia, the risk is more than without atypia. So the treatment will vary. In young patient without atypia, we can just go for progesterone therapy, which nullifies the estrogenic effect and treats the condition. But if there is atypia present, then there are higher chances of converting into CA. So you can go for simple hysterectomy. But if she wants to preserve fertility and menstrual function, then you can go for high doses of progesterone. In complex without atypia, you can go for progesterone doses. But if there is atypia present, then you should be going for TH with BSO. But if she wants to continue fertility and menstrual function, then the options are either high doses of medroxyprogesterone acetate or Mirena. Mirena acts superbly. You put that IUCD and it releases progesterone, and that takes care of the hyperplastic endometrium. The only thing, follow-up is must when you are conserving the uterus. If the patient is old, then in low-risk cases like simple without atypia, we can give progesterone therapy. But with atypia, always go for TH with BSO. Complex without atypia, progesterone is the option. With atypia, again the treatment is only and only abdominal hysterectomy with bilateral salpingo-oophorectomy. Now, what are the nodes involved in C endometrium? The uterus has different lymphatic drainage depending on the location. From the fundus, the lymphatics are drained into para-aortic nodes. From cornu, they go to superficial inguinal nodes. Middle part from body, external iliac nodes, and from cervix, external as well as internal iliac. So the important nodes are para-aortic, inguinal, external and internal iliac groups. Staging. This is a surgical staging again. Stage 1, the growth is confined to the corpus of the uterus. Stage 1A, growth is only from the endometrium. There is no myometrial invasion, is stage 1A. 1B, myometrial invasion has started, but it is less than half of the myometrial thickness, stage 1B. Stage 1C, when myometrial involvement is more than half, more than 50% of the myometrium is involved. There are many MCQs on staging of the C endometrium, because when we operate on the patient, first thing we do is surgical staging. You go, you look at the uterus, serosa is intact, then transabdominal hysterectomy with bilateral salpingo-oophorectomy is done. You cut open the specimen. Once you cut open the specimen, you see the growth. If it is coming from only endometrium, you are happy that the patient falls in 1A group. If there is myometrial invasion, then you have to see whether the invasion is less than 50% or more than 50%. You can even send frozen section for grading of the tumor. And this step is important because whether you have to go for lymph node dissection or not is totally dependent on these conditions. If the stage is early, there is node involvement only in 2% cases. So if there is myometrial involvement present, you have to go for lymph node dissection. Or on grading, if there is higher grade, grade 2 and 3, or maybe clear cell carcinoma seen, then you have to go for lymph node dissection, that is pelvic and para-aortic nodes. If the nodes are positive for malignant cells, then you have to go for post-operative radiotherapy. In stage 1A, the node involvement is just 2%. But as myometrial invasion goes on increasing in stage 1B and 1C, node involvement is seen in almost 10 to 40% of the patients, and thus the mode of treatment would be surgery and post-operative radiotherapy. So whenever MCQ is asked, it is always like, the myometrial invasion is not found, what will you do? Myometrial invasion is less than 50%, what will you do? It is more than 50%, what will you do? So you have to understand the staging, and depending on that, whether lymph node dissection would be done and post-operative radiotherapy would be required are the answers. Stage 2, the growth has reached up to the cervix, but it does not extend beyond the cervix. Stage 2A, there is only endocervical gland involvement. Stroma is not involved. And stage 2B, along with the glands, even cervical stromal invasion is seen. In this, as the cervix is involved, we would like to give brachytherapy plus, where the radiation acts on the lesion, it reduces the lesion, and then we go ahead with TH with BSO. And if required, if the nodes are positive, then we go for external radiation, which is most commonly given. Because as the involvement increases, node involvement will also increase. We can also go for modified radical hysterectomy, that is Vardheim's hysterectomy in these cases. Stage 3, there is local or regional spread. 3A means involvement of the adnexa, and peritoneal wash will show positive for malignant cells. Stage 3B, the growth has extended to vagina. Stage 3C, pelvic and para-aortic nodes enlarged. So in these cases, surgery has very limited role. We have to go for chemotherapy to sensitize the patient for radiotherapy, and main mode of treatment would be radiotherapy. Stage 4, the tumor has distant metastasis, involvement of bladder, bowel, mucosa. Stage 4B, there is presence of intra-abdominal and inguinal nodes. Again remember, presence of inguinal nodes or enlargement of inguinal node directly puts the patient in 4B. Whereas, going back to the last slide, involvement of para-aortic and other pelvic nodes keep the patient in 3C. So staging can be asked, or MCQ can be asked on this, that patient showing inguinal nodes. The answer would be 4B. If involvement of para-aortic node is seen, the answer is 3C. In stage 4, mainly treatment is palliative, radiotherapy or chemotherapy or hormonal treatment to increase the tumor sensitivity. Indications for lymph node dissection, again I am making it very clear. For pelvic and para-aortic, you have done this surgery, you have cut open the specimen, send it for frozen section, you are waiting for the report. Tumor histology comes as clear cell carcinoma. You know it has malignant potential, worse prognosis, go for lymph node dissection. Papillary serous, again the second type where the prognosis is bad, very malignant potential, go for lymph node staging. Squamous cell carcinoma, go for surgical lymph node dissection. If report is adenocarcinoma, but the grades are grade 2 and 3, you have to go for lymph node dissection. If myometrial invasion is more than 50%, go for lymph node dissection. If there is isthmus cervix extension, you have to go for lymph node dissection. If there is any evidence during surgery, you find that the growth has reached to the adnexa, to the neighboring structure, immediately you have to go for lymph node dissection, because the disease is not just confined to the uterus, it has gone beyond that. Lymph node involvement, there are great chances. So this patient would need radiation therapy later on. Treatment, only chemotherapy has no role in the management of C. endometrium. It can be used to sensitize, but main base treatment is surgery and then adjuvant radiotherapy. Indications for radiotherapy, whenever there is extrauterine extension, lower uterus or cervix involved, the type on histology is papillary serous or clear cell, or if it is adenocarcinoma grade 3, that is poor histological differentiation, myometrial invasion more than half, and if there is presence of pelvic node, then we have to go for radiotherapy. Prognostic factors: if there is lymph node metastasis, the prognosis is bad. Stage of the disease: as the stage progresses, prognosis is bad. Histological grade: grade 1 has good prognosis, 2 and 3 and beyond, the prognosis is bad. Age at diagnosis: older the patient, prognosis is bad. Myometrial penetration: more the penetration, worst the prognosis. So these are the things which tell us how to manage the patient in CA endometrium. What are the risk factors? What is the pre-malignant condition? How we can treat it? When the CA is detected, depending on the stage, what treatment, whether surgery would suffice or in addition to that radiation would be required. We have seen that. So this covers the whole topic. Thanks a lot.